Welcome to another episode of 7 Minutes Medicine. Today we're going to talk about the management of pulmonary embolism. Please check our video about the diagnosis of pulmonary embolism if you did not did so. So first, the management guidelines. We are aiming toward respiratory support, circulation support, empirical anticoagulation, and the thrombolysis. For the respiratory support, our goal is to keep oxygen more than 90%. We might need to do intubation if there's severe hypoxemia with collapse, and we have to make sure that we are using low plateau pressure because intubation may result in collapse and hypotension giving the right heart failure. So we have to have an expert to do the intubation if the intubation was done before the management of the clot. So the next step is circulation support, and to do that, we can give IV fluid boluses, 500 cc's to 1,000. The idea is to support the preload, but we should not overdo it because this will result in RV overstretch and worsening RV failure. The second option we have is to use vasopressors. Norepinephrine is the most preferred because it has less likely to cause tachycardia. You can use dobutamine to increase the contractility, but it can result in systemic vasodilation. This will result in decrease the preload, so we have to use it together with the norepinephrine. For the empirical anticoagulation, if the patient is unstable, we start anticoagulation with a presumptive diagnosis, even without a CT angio. So if we are able to do bedside echocardiogram and lower extremity Doppler, this will help in guiding our decision. If the patient is stable, we give empiric anticoagulation if, as we said, high probability patient. In our lecture, we decided how to decide how high probability patient from the Wills score. If you have intermediate probability patient, but the confirmation, like the CT angio or the VQ scan, will take more than 4 hours, or low probability patient if the diagnostic confirmation will take more than 24 hours. But all of this applies if the patient does not have a contraindication for anticoagulation. So the anticoagulation options, we can start by enoxaparin, the other named Lavonox, with warfarin bridging, 1 milligram per kilogram BID, more preferred than the 1.5 milligram per kilogram once daily. We can also give 10 days of enoxaparin, followed by dabigatran or edoxaban, the oral anticoagulant. Rivaroxaban and apixaban, you can use them as a monotherapy without a bridging, and this is very easy application of those medications. The duration of a treatment, you give it for 3 months minimum after the first episode, either provoked or unprovoked. Then you have to individualize the decision. Some literature supported the use of enoxaparin in a cancer patient. Next, we're going to talk about the indications for thrombolysis. So the first indication is if the patient has high risk. As we said in our previous lecture about the diagnosis, if the patient has massive PE. The second indication, if the patient has submassive or intermediate risk PE, and as a refresher, it is RV strain without hypotension, but the massive is hypotension. So if the intermediate risk or the RV strain APE without hypotension and there is elevated troponin and BNP, we have to consider it as high risk category intermediate PE. And there is another score that we can use to define the high risk category in the intermediate PE. It is a simplified pulmonary embolism severity index. If we have one or more of the following: the age more than 80, cancer, heart rate more than 110, systolic blood pressure less than 100, chronic cardiopulmonary disease, and oxygen saturation less than 90%. So if we have any of those, one or more, and we are having intermediate or submassive PE, then the patient may benefit from thrombolysis. So first, we will talk about thrombolysis in the high risks, massive PE. Systemic is more preferred than localized or catheter-directed for unstable patient. We can give alteplase 100 milligram over 2 hours. If very unstable, we can give bolus. And we have to give IV unfractionated heparin after the TPA, at least for 24 hours before flipping to any other anticoagulant. We have to stop anticoagulation at the time of the systemic TPA, and we have to stop it also if there is severe bleeding. We can use cryoprecipitate and fresh frozen plasma. And the catheter-directed thrombolysis can be used instead of systemic if there is high risk of bleeding or there is failure in the systemic TPA. Thrombolysis in the intermediate risk PE, and we highly recommend it to be done as we talked earlier. If there is severe hypoxemia, there is tachycardia more than 110, there is extensive clot burden. The catheter-directed is more preferred than the systemic in this category, and the reason is to decrease the pulmonary hypertension, because even if the patient is stable, why to use thrombolysis? Because if the clot stayed, in the future, those patients may have a risk of developing CTEPH. CTEPH, like a chronic thromboembolic pulmonary hypertension. To prevent that from happening, we have to do thrombolysis catheter mediated. So some final thoughts. IVC filter can be used if there is contraindication for anticoagulation, even without evidence of lower extremity clot. Embolectomy, if the patient is unstable and TPA is contraindicated, embolectomy can be tried. And outpatient management can be done if the patient is low risk, no respiratory distress, normal pressure, no recent bleeding, no comorbid heart, lung, liver, renal, and normal mental state. Thank you so much for listening to our lecture. Please, if you like our content, subscribe for more useful lectures. Thank you.